This conference will now be recorded.
All right, so we're gonna work on neurologic emergencies today. First and foremost, can everybody hear me? Or is there anybody that can't? I guess that's a really bad question, actually. Yes, all right.
I can hear you.
Getting some yeses. All right, so neurologic emergencies. I believe some of you may have read the chapter. Hopefully all of you read the chapter, but realistically, we've all been students, and I know that that's not the case. So we're going to go over a bunch of different things regarding the brain. So hold on, I thought I had muted that already. We have the competencies that we're planning to meet. I'm sure that you're all familiar with them, so we won't spend an awful lot of time. The anatomy, physiology, pathophys of all these different things, including seizure, stroke, status epilepticus, and just the general headache. Because we all know that we do actually get called for those, so that's always fun. So stroke is the 5th leading cause of death in the United States, and the treatments are based on the type of stroke that somebody's experiencing, whether it's ischemic or hemorrhagic, and there are all kinds of different treatments that can be used based on which kind of stroke that a person's experiencing and which hospital you bring them to. So that's always something important to consider. And then here's a list of reasons that seizures may occur. Another thing that we're going to focus on for today is some altered mental status, which you can get for all kinds of reasons. I know when I show up for altered mental status in seniors, one of the first things that I usually think of is, are they having a UTI or sepsis? So that's something from, I used to work in senior home care, and that's something that I picked up there and have not let go of yet. There are definitely other reasons, but that's one of the most common in the senior population. But there are other things. They can be drunk. They could have hit their heads, things like that. So that's a lot of that you're going to get from getting your history, making sure that you're going through and finding out as much as you can about what's going on with the patient from themselves, as well as from anybody else that is familiar with them in the area. So anatomy and physiology of the nervous system is on your screen. I'm not going to read it to you because you're all adults. But the most important parts of it are the brain, spinal cord, and nerves, naturally. I know we're going to go over some parts of the brain. So I do have, for all of you that are I got my little All right, so we have different parts of the brain that control different things. You're going to notice that if you take the time to learn the brain and the different cords, nerves, and things that are running through the body, you'll know what different parts of the area of the head are controlling. So if somebody gets hit in the head in a certain spot, you have a general idea of what that, I always say it wrong, coup, counter coup, what parts of the brain may have been injured in that fall or that strike. So it can be very useful. I'm going to be honest, if you ask me what the third nerve did or something like that, I don't know. I did when I took my exam and then I forgot it. So see if I can get my computer to work. There we go. So we have the central nervous system and the peripheral nervous system. They do different things. They can control breathing, heart rate, blood pressure, temperature, and those are constantly controlled in a way that you don't have to think about them for yourself. Your brain is doing it on their own. So that's useful. It's nice that you don't have to think to yourself, breathe, 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 heartbeat, breathe, breathe, heartbeat. It'd be the other way around because you want your heart to beat a lot more often than you breathe. But so it also controls all of your bodily functions. It controls the fact that I'm nervous as anything right now because I don't usually teach. It also controls the words that are coming out of people's mouths, and that's why you'll notice with certain strokes, you'll have people that can understand what you're saying, but then they can't speak for themselves the words that they want to say. So when we get to the stroke scale, we'll go over the types of questions that you need to be asking, and you'll note that I'm sure you learned in your basic class as well. You're going to have people repeat a sentence after you, and that's going to help you determine if they're understanding what you're saying, as well as able to say what they have in their brain, make it come out of their mouth. So we will go over that more then. There are the three major parts of the system. You have the brainstem, the cerebellum, and the cerebrum, and you'll see that displayed on your screens. And the brainstem controls most of our basic functions. So that's the breathing, the blood pressure, pupil constriction, when you swallow, just things that you're not always thinking about again. So the cerebellum controls the muscle and body coordination, which means that it can help coordinate the tasks that involve voluntary movement of the muscle. So when you pick something up or something like that, you're using your cerebellum because it's one of those ones that's voluntary movement. And then the cerebrum has the right and left hemispheres, which it controls the activities on the opposite side of the body. So you'll note that when somebody has, going back again to strokes, somebody has a stroke on the left side of their brain, the right side of their body is likely going to be the side that's affected. So you need to be aware that if you're noting things on, again, if somebody hits their head on the left side and it does manage to have significant enough impact on their body that they have deficits from it, you'll be able to tell if it was that coup or that counter coup based on which side of the body is having those deficits. So they were hit on the left side of their body, but it's also the left side of their body that's having issues. It's not from the strike itself so much as from the brain doing its whole little bouncing back and forth inside the skull. It hit the right side harder because it's the right side that's having those deficits, which is causing the left side of your body to be a little bit off. So different parts again of the cerebrum is the front is going to control your emotion and thought. The middle part is controlling touch and movement. The back processes sight, which is so weird because it's as far away from your eyes as possible. And in most people, speech is controlled on the left side of the brain near the middle of the cerebrum. But that's not always a rule. So similar to anything in the body, there can be some people that have things that are weird, which is not to get too off topic, but with your heart, the way that your blood supplies your heart changes from person to person. So it's the same thing with parts of your brain. So the messages that are sent to and from your brain travel through your nerves. You have the 12 cranial nerves, and those are the ones that uh, feel free to go and learn them. It's not bad information to have, but if you ever walk into a hospital and give your radio report, you wouldn't do that in the hospital. If you ever walk into a hospital or you give your radio report and you tell people which cranial nerve it is, it might be useful for the doctor, but I would not put it in your report because you don't have, even though you may know it, you don't have significant enough testing and imaging and everything in the field. And if you were to go to the stand, you don't want to have them be like, well, how did you know it was the third cranial nerve? So for all the rest of the nerves, they join the spinal cord. So the 12 cranial nerves run directly, like it says, but the rest of them through the spinal cord. So the spinal cord's pretty important. It does have all kinds of different nerves, and that's why you'll note that C345 keep the diaphragm alive, because they have the nerves that allow the use of your diaphragm. So here it's going to go over what is controlled by different things. So at each vertebra in the neck and back, 2 spinal nerves branch out. And these correspond to different parts of the body and what they control. So the neurons and impulse transmission. Oh, I should have pulled up a video for this one. It's actually really cool to watch the way that they communicate in real time. It's actually probably sped up pretty quickly or slowed down. Either way, it's really cool to watch them they walk along each other so that they can communicate with one another. It's amazing the things that your body does at such a tiny cellular level. So the axons and the dendrites and the cell body, all these things are working together to make sure that your body is communicating with itself as needed. So if something were to stop communicating in the appropriate manner, your body might not know that your hand is on the burning stovetop. That's one of the important things that those nerves and everything do, is tell your brain, hey, don't do that. So yeah, that video is probably definitely slowed down because it needs to travel to your brain so quickly. So here you have an image of those pieces, and then you would note, I'll pull up that video during the first break so you guys can see it, just because it's cool. You have to be able to communicate, they have to be able to communicate with one another, and there is that space in between, and so they have to be able to get from one to the next. So the brain is very sensitive to changes. It's one of the first parts of the body that is going to be sensitive to changes from your homeostasis. So it's the most sensitive, of course, like it notes, to oxygen, glucose, and temperature. And a substantial change in one of those levels would cause your brain to not function in the way that it's intended to. So you've probably heard of febrile seizures. That's usually noted in small children. Something that you see there is that they may have been sick for a little bit, but they didn't have a fever. But right now they have a fever of 103, and their mom is like, "Hey, no fever 20 minutes ago," but the baby just started like seizing, and that could be because of that enormous change in temperature. The brain doesn't know how to cope with it right away, so it just freaks out. So that's one of those changes that you'll note. Another thing, again, seizures, if you have somebody that looks like they're having a seizure, a stroke, really anything that looks neurological, make sure that you're testing that blood glucose level, because it could be as simple as their blood sugar is a little bit low. You can give them some sugar. At the advanced level, you'll be able to do it with D10 if you weren't able to get them to follow instructions well enough to take oral glucose. So those things are so easily fixed. But if they are not fixed, it can become such a massive problem that it's one of those things that you want to make sure that you're checking very quickly. Oxygen level, so easy. You just throw on a nasal cannula and go from there. If you need to do more, you can do more, but that's at least an initial really quick fix that could save them brain cells. Um, timer cells. So the longer that it takes you to realize that that blood sugar is 20 or their oxygen saturation is 72, the more brain cells that they're potentially having issues with. So you want to make sure that you're checking those quickly. Other things that are important, and of course, it's the way that the oxygen and the glucose get to the brain, is blood flow. So without blood flow or with low blood flow, things can change for the way that the brain operates. So um, something to consider as well is, especially patients that are losing a lot of blood, making sure that they're in a position so that their brain is still getting the blood that they need. So if you have somebody that's had massive hemorrhage, not just because of C-spine protection, but also to make sure that the blood is not working even harder to get to the most important part of the body for it, try and keep that patient lying flat, or possibly even in Trendelenburg, where your head is a little bit lower than your feet. Not usually possible on an ambulance stretcher, but if you're ever working in a hospital, something like that, um, not something to be taken lightly, because that lack of blood can cause additional issues. So now you already have the problem where they're bleeding, and now you're also going to end up having them seize. So looking at stroke first, which again, fifth leading cause of death. I don't think that'll be on any of your exams, but still interesting to know, because it is one of the things that you might see more often in the field. So the definition of a stroke is that interruption of blood flow to the brain, but it can be caused in two different ways. So again, I know you are all already basics, so most of you are probably familiar, but you have your ischemic versus your hemorrhagic stroke. Both of these cause a change in the blood flow to the brain, and it's sudden, and like it says, it results in a loss of brain function. But the difference is whether it stopped the flow of blood because there's something in the way and it's not flowing at all, or that blood is attempting to flow through, but instead it's being released into other areas of the brain. Both can, of course, be fatal. Hemorrhagic can be a little bit worse because they're also bleeding out. And then when they bleed into the space in the brain is then being the cranium is being taken up by not just the things that belong there, but also this additional blood, causing it to compress in on itself. So now you have multiple issues. So something you'll notice with stroke patients is that they may not understand their symptoms, or they may even tell you that they're not there. So when we get to the stroke scale, we'll talk about, different things that you're looking for and testing for. But something you might note is when you have them squeeze your hand and they think they're so sure themselves that their squeeze strength is equal, but it's not. Not only is the lack of equal strength a notable finding, but the fact that they don't know is a notable finding. Or if you stroke both of their like wrists and they can tell that you're stroking one but not the other, that's again them not being able to tell is a finding. So in my notes over here, I have again time is brain. So that's something that is true throughout any issue with the neurologic system. So you always want to find these as quickly as possible and get them to the hospital quickly. You can call for a medic. A medic may be very useful in certain aspects, especially a stroke that is getting so significant that the patient's airway is potentially compromised. Um, you can call for a medic because if the patient needs to be intubated, whether they're not conscious enough that any medic can do it, or if they need to be RSI'd, then calling for an RSI medic specifically. That's one of the few things, though, that a medic can truly do different for a stroke. So, in general, your solution to finding a patient with stroke is just getting them there quickly. At the advanced level, you'll be able to start giving fluids. And then there will be a discussion too on what are the benefits of normal saline versus lactated ringers. Um, and there are studies that go either way. That ends up to an extent becoming personal preference because our protocols don't currently have a set list of this is when you're going to use this one versus that one. But I know for me personally, I tend towards lactated ringers in patients that have any sort of neurological issue because it's a little bit more near that homeostasis for the bloodstream. So here we're talking again about the different types of stroke, ischemic and hemorrhagic. So you'll see that over time, those signs and symptoms increase dramatically more with hemorrhagic than with ischemic. And like we talked about, that may be because the blood that's coming from that hemorrhagic area is now taking up space inside of the head that was previously being used by the brain. So looking at ischemic strokes specifically, um, this is when the blood vessel is blocked off. So the clotting that can be caused by a variety of things. Something that's notable, I know that at the advanced level you can't look at an awful lot of 4 leads and 12 leads, but at this point you're probably at least a little bit more familiar than generally basics. And so you might note that somebody is having atrial fibrillation. When they're in AFib, they have that change in the way that the blood is being pumped through their heart. So there's a possibility that there's going to be some buildup in those atrium, and you're going to want to. That's a notable finding because that buildup can cause some clotting within the heart, and then when it is eventually sent out of the heart with an adequate pump, it could end up in the brain. So that may actually be the most common reason that somebody has an ischemic stroke. So it is something that you want to make sure that you're doing when you're thinking that somebody's having a stroke is put on at least a 4 lead. Again, at the advanced level, it's probably a little bit safer to just go straight for the 12 because there are only so many rhythms that you're able to interpret. I don't recall what they all are, but I don't think AFib is technically one of them. So I wouldn't note it in your report that you saw AFib on a 4 lead, but it's good for you to know in the field. So some symptoms, you're going to notice that loss of movement on opposite sides of the body. So like we talked about, if it's something on the left side of the body, then it's probably the right side of the brain. So on and so forth. So it can be hardly any symptoms at all. Not to make this like, here's a call that somebody was on. But I know something that was notable for me was I was on a call that I was so sure was just a pinched nerve in somebody's shoulder because the only symptom they had was that their arm was kind of tingly. Their hands felt tingly. You know how when your arm falls asleep and then you have that tingly sensation? That was his only complaint. And it turns out that he was indeed having a stroke. So sometimes those minor details actually are a finding, a very important clinical finding. So don't discredit somebody that has that arm feels asleep kind of feeling. That could be the only symptom that you see, and it's still important to get them to the hospital. Once that clot is there, it's much easier for that little bit of blood that's still getting around it to be carrying just enough platelets or whatever else might be in it that are going to catch on that clot and cause it to become bigger and eventually more devastating as far as symptoms. So again, that small symptom at the beginning is indicative potentially of things to come. So it is still important. Hemorrhagic stroke. So this is the one that's bleeding inside of the brain. They, again, one of the most common things that you're going to find. So with ischemic, one of the most common things you're going to find is that AFib. With hemorrhagic, one of the most common things you're going to find is hypertension. This is why we tell people that have hypertension just at a baseline that they need to be going to see their doctor. They need to get on some medication for it. A lot of people are like, oh, it's always like that, and they are not that concerned. If I have a patient that has 180 over 120 or something like that, and they say, oh no, that's fine, that's what I'm at all the time, I'm going to urge them to go and see their PCP even if they don't go to the hospital with me that day, because that chronic hypertension like that can lead to so many other things, one of them being hemorrhagic stroke. Like I said, hemorrhagic strokes are often fatal because they happen so quickly. If we go back to this, you can see that over time, those signs and symptoms again get so much worse, so much faster. Unfortunately, there's no actual unit of time for you to see how quickly that can happen because it does change based on the location in the brain and the way that the patient's treated and how quickly you get them to the hospital and all of that. So you want to be making sure that if you think that it's hemorrhagic, you are getting them there as quickly as possible. So one of those things that you're looking for is that hypertension. I've also noticed just from hearing stories about people that have had hemorrhagic strokes, and I don't know if there's any actual clinical research that supports it. People that are having hemorrhagic strokes seem to be more likely to have vomiting, like that they're sitting on the edge of their bed and they vomit so severely that it ends up like on their ceiling and their walls. So that seems to be indicative more of hemorrhagic stroke than ischemic, but again, that's just from stories. That's not don't quote me. So because the blood is ending up inside of the brain instead of in the veins and the arteries where it belongs, the brain tissue ends up compressed. Then when it's compressed, the oxygen now can't get through the blood to the area that's being compressed because the blood is not flowing appropriately. So now you may end up with almost symptoms of both sorts of stroke because you have the hemorrhagic and now it's causing a lack of movement of blood into a different area. So now you have ischemic symptoms as well. Some people may know that they're at risk for hemorrhagic stroke if they have an aneurysm that they're aware of that hasn't ruptured, but they know that it may rupture at any time. That's something that you can get from history. That's not super common. Usually people that have an aneurysm that is that high risk of rupturing either don't know about it or they know about it and their doctor is doing everything that they can to take care of it as quickly as possible so that it doesn't end up a hemorrhagic stroke. However, they can happen very quickly. So it's just, have you guys gone over the linings of the artery? There's the 3 layers. I'm gonna botch their names. I'm not even gonna be able to think of their names. All right, so I see it briefly. So let's see. That's not what I wanted. Well, here's a Google image search. So you have the tunicas. Um, when you have that artery initially forming, you're going to notice that somebody has, or you're not going to notice because you're not going to see it in the field, but it would be noted that this tunica intima had a small tear. And that could be caused, again, we're looking at that hypertension as a likely cause. So that patient has had the hypertension long enough that their artery has not been able to support the amount of pressure moving through their system. So it's going to cause a small rupture in that tunica intima. And then because of that rupture, as blood's passing through that area, some of it's going to get stuck inside, like in between the layers. Um, and as it gets stuck in those layers, it's going to cause that entire artery to expand, because it's got that little bit more than it's supposed to. That buildup of fluids in between those layers is going to cause the outside layer to expand out, but it's also going to cause the inside layer here to push in on the blood flow. So you may even notice that patients have a little bit of, again, ischemic-like symptoms just before they have those hemorrhagic symptoms. And that's going to be because the buildup became significant enough that it may have blocked off, similar to if it were a clot, but this is still fluid that could move. Eventually, though, it will break through the tunica extrema, and that's when you'll end up having that full hemorrhagic stroke, because now there's this open portal for blood to flow through. So some symptoms that you're going to notice for hemorrhagic is that sudden onset of a severe headache. It's going to be noted as the worst headache of a person's life. And that's one of the things that hopefully you'll note quickly, because they may not be able to tell you that they have it after the next couple of minutes, because it could get worse that quickly. So you want to get as much history as possible from anybody that's having any sort of stroke. You also want to see if you can bring somebody that is familiar with them, has been with them for the period that they've been having these symptoms. So if they have had the symptoms briefly and their significant other, or if they're senior and it's a caregiver or a child or something like that, that's not like a small child, but one of their children that is hopefully now an adult, bring them with you. Put them in the front seat, bring them to the hospital. Don't let them drive themselves, not because you're concerned that they're not going to get there safely, but because the hospital staff is going to have questions for them immediately, because the treatment of strokes is very time dependent. So if you can provide somebody that can say, yes, they were acting totally normal 25 minutes ago, as opposed to you saying that somebody told you, because now you're getting it third hand. So bring that person with you so that they can give as much information to the hospital as possible. So a hemorrhagic stroke, surgical repair is a possibility depending on where it is, how it happened, how far along it is. So try to bring them to a hospital that has surgical capabilities, um, like brain surgery, not just regular surgery. However, don't delay care for it specifically. So if you have two hospitals in equal distance and one of them is more likely to have stroke care, then bring them there. But if not, if you're talking about, I know you guys have class in Tamworth, so if you're talking about that area and the difference is bringing them to Huggins versus bringing them to Portsmouth, don't go to Portsmouth just for this, because you can bring them to Huggins and Huggins can get more imaging and figure out exactly what's going on and which kind of stroke it is and go from there. So intracranial pressure, ICP. So as we talked about, the bleeding within the brain increases the ICP, and then the amount of blood that is moving through the brain is decreasing. This can cause that herniation. Something that we've talked about previously, and studies have been showing varying results. If you have somebody that is having possibly increased intracranial pressure, something that you can do is breathe just a little bit faster for them. You don't want to breathe so quickly that you're over oxygenating or you're like breathing them so fast that they don't have time to exhale or anything like that. But if you're bagging somebody and you have an end tidal of 45, increase that respiratory rate just enough that maybe you can bring them down closer to that 35 area. And this can help with some of the intracranial pressure because it changes the way that oxygen is being carried through the blood and therefore is hopefully providing additional oxygen in the blood and therefore allowing that exchange to happen at a higher rate per drop of blood that's getting through. And this has gone back and forth. There have been studies that have said that you should breathe for them so quickly that they end up with an end tidal of 25. Studies have more recently been saying don't do that. Keep it within that 35 to 45 range. But if you can get them down to that 35, it can help for sure. Um, in general, though, your pre-hospital treatment is not going to be effective at decreasing their ICP. So just because you're breathing a little bit faster for them or you're instructing them to breathe a little bit faster, be cautious there. Just because their end tidal is 35 as opposed to 45 doesn't mean that you fixed the problem. So you're not able to decrease the ICP. You just might be able to possibly help with slowing down the amount that it's increasing. So still get them to the hospital as quickly as possible while still being safe. So you'll see here your normal brain layout versus when you have the increased ICP. As the blood is taking up the space, it is causing that brain to almost fold in on itself. TIAs are like strokes, but some people call them mini strokes. They're not really a mini stroke because they resolve. Um, but if you have a patient that says that they've had mini strokes, it can be a precursor to a true stroke. Um, a lot of patients don't have the medical training, of course, that we all have, and so they may not know TIA or transient ischemic attack. Those words mean nothing to them. But if you tell them they had a mini stroke, that's going to stick with them a little bit easier. So when they tell you they had a mini stroke, they're probably talking about a TIA. Sometimes they truly mean that they had a tiny stroke that has since like been resolved medically and they've managed to regain function. But in general, I found that mini stroke means TIA. These are strokes that subside on their own within the 24 hours. However, they still can present exactly like a regular stroke. So there's no residual damage, which is great for the patient, but it is a precursor generally to a regular stroke because the cause of that TIA is still typically a blood clot. It's just that the blood clot has managed to break down on its own. The fact that they've had a blood clot form enough to cause these symptoms in the first place is indicative that they are likely going to have it form again and not be able to break itself down. So they are still an emergency and they should still be evaluated. Even if by the time you get there, they're like, oh, I'm perfectly normal now. Still try to bring them in because they should be evaluated. So some signs and symptoms of stroke. I'm sure you're all familiar from basic class and basic practice out in the field. Facial drooping, sudden weakness or numbness, the loss of balance, decreased movement. These are the things that you're testing for when you do like a Cincinnati stroke scale or a FAST-ED stroke scale, or whichever scale that you elect to go with. These are the things that you're generally looking for the most blatantly. But then you'll also notice some of the more mild issues. So you have dysphagia with a G and you have dysphagia with an S. Dysphagia with a G is the inability to swallow normally, and the dysphagia with an S instead of where the G is the inability to speak normally. And these are both possibly symptoms of stroke. I usually just say they can't speak normally or they can't swallow normally rather than trying to explain which dysphagia you're talking about, because at least the way I pronounce it, they sound exactly the same to me. So there's also the possibility that you're going to have some tongue deviation. You're going to notice some snoring, respirations, even while they're awake and looking at you, because let's say it's a right side of your brain, so the left side of their tongue is not something that they're able to control right now. So they may have that tongue is like moved to the left side of their mouth and is kind of just hanging there. The tongue is the largest muscle in your body. If you were to stop being able to flex it and use it as you normally do, it would close off the airway. So that's one of the times that you might want to consider starting a medic for a stroke, is that if you notice that tongue is not cooperating normally, because that can lead to a blocked airway. So here you'll see which side of the brain can cause which types of issues. So like we were talking about, the left side of the brain usually causes issues with the right side of the body. But you're also going to notice the different kinds of symptoms that you'll note that are because of the side of the brain. So when a patient can understand what you're saying, but can't communicate what they're trying to say, and I'm not going to be able to remember which side is which. One of them is on one side of the brain and the other's on the other. And then if they can say what they want to say, but they can't understand what you're saying, that's the other side of the brain. If the patient is not able to understand what you're saying and not able to communicate for themselves, now you're looking at an issue that may be across the board, both sides of the brain, or could be in the middle, like midline. So here it is. The left side of the brain can cause receptive aphasia. So that's the trouble understanding speech, but they can speak clearly. I was wrong. Or the expressive aphasia. They could also understand the question but can't produce the right sounds to provide the answer. The right hemisphere, on the other hand, they'll be able to understand language and be able to speak, but their words may be more slurred and hard to understand. So, my bad. Glad we caught that quickly. Hopefully before you all wrote it down in the notes that I'm sure you're all taking, because I'm just that riveting. Does anybody have any questions so far? This is the end of the primary stroke section. Does anybody have any questions on strokes? I'm getting a lot of no's. Before we get into conditions that may mimic strokes, such as the hypoglycemia that we discussed already, why don't we take 5 minutes? So meet back at 6:53 is what I have on my clock. Grab some water. I need a break. So I'd imagine you all do too. If you do have any questions during those 5 minutes, feel free to just type them in the box and I'll get to them when we meet again.
This conference will now be recorded.
All right. So hopefully everybody's back. I did pull up that video of the protein walking around on the nerve because I just think it's really interesting. I don't know if it has sound. I will check in a second if it does. If it has sound and you guys can't hear it, please let me know because I do also have videos on the different types of aphasia for you. And that definitely needs noise. So there is no sound on my end. So, but look at how it communicates with each other. How cool is that that's happening at this microcellular level? That is such a tiny little thing that's going on in your body, and it happens so quickly so that your body can communicate with itself. Otherwise, things wouldn't happen the way that it's supposed to. All right, so let's try this, and somebody let me know once it gets to the point where they're speaking if you can't hear anything. Helps if I unmute it first. So this is the aphasia in which they can't understand you. Oh. All right, I think I said that it was the one where they couldn't understand, but I had the wrong video up. So that was the one where he could understand, but then he was having a hard time. I'm confused. Anyway, here's the other one. Also need to unmute it. All right, I see that people are saying that they're not hearing anything, and I apologize for not noting that first thing. So you can see from the clip at the bottom whether they're able to understand what's being said or not, based on the closed caption. I'm very much a closed caption person. What's my name? Laurel. Sorry about that. I probably should have started with that at the very beginning. So you'll note, like from the bottom here, that he's struggling to come up with the words. So the last one, he could come up with the words that he wanted, but he couldn't understand what was being said. And then this one, he can understand what's being said, but he's having trouble coming up with the words that he wants. So you can see from just the closed caption, even without the sound, because I honestly don't know how to give you sound. I'm not technologically savvy, that he's struggling to speak, whereas the other one could just talk all day long, but it wasn't necessarily about what you asked about because his brain couldn't comprehend what the questions were. If people are interested, I will put the links for those in the chat box so that you can take a look at them in your own time, possibly. So there's this most recent one. That's the one that he was having trouble speaking. And then the receptive aphasia. Is right there. So if anybody's interested, I think it's a pretty cool thing to see so that you know what to expect and what you're looking for in the field, because both of them were able to construct sentences. Most likely they've also both gone through a fair amount of therapy for that. Usually that's occupational therapy that helps them with things like communication, but even somebody that's having that stroke actively in the field, you may notice that having that experience of seeing what to expect depending on the type of aphasia can definitely help. All right, so things that can mimic a stroke. You have the hypoglycemia, postictal, and then subdural and epidural bleeding. Although subdural and epidural bleeding are within the skull, they are not within the brain. So they're not quite the same as hemorrhagic stroke. But again, they're going to cause that change in ICP and that inability for the blood to circulate the way that it was supposed to, because you'll note right in this area, that part of the brain is being pushed down, even though, same with here, even though the bleeding is not within the brain itself, and that's going to cause that similar symptoms. So subdural bleeding, epidural bleeding are usually results of trauma. The dura is that leathery covering that you find over the brain. It's right next to the skull. And you might notice that if somebody's having a dural bleed, or even a subdural bleed, you may also note that there's a fracture near that area of the skull, because it could cause the fracture could cause that artery to start bleeding, which again creates that pressure in the brain. With both types of bleeding, the onset of those stroke-like signs and symptoms could be very subtle. It could take a while for them to show up. And hold on one second, because the dog's having a crazy moment. Here you go. Sorry, I didn't realize nobody else was home. So those onset of the stroke-like symptoms can be kind of subtle, but if you have somebody that hit their head, and then you start noticing halfway to the hospital that they're having stroke-like symptoms, there's a higher likelihood that it is a bleed, like a subdural or epidural bleed, more so than that they coincidentally had a stroke 20 minutes after they fell and hit their head. You'll also find that the rate of the bleeding will change things. So when you have different types of bleeds in different locations, you'll have different presentation of symptoms. I'd imagine that you guys will go over that more in like a head trauma section, but it's probably too much to go over in addition to everything we have to cover today. So getting into seizures. Seizures are the sudden and erratic firings of neurons, as it says here. And there can be all kinds of symptoms for those. It can be very, very mild. There are people that have absence seizures, and the entire presentation of that seizure is that they just kind of like stare off into space at nothing, and it's like they're not even inside of their head for however long that is occurring. And that's going to be very, very hard, if not impossible, for you to diagnose in the field. It's not something that you need to be able to say that person's having absence seizures. If somebody says that they have a history of absence seizures, that's definitely notable, something that you want to make sure that you're aware of, because all seizures can end up becoming more severe. So, but it could be something as mild as that to this whole tonic-clonic, their entire body is having this crazy moment of just shaking all over the place. Before we get too far into seizures, and this one doesn't really need sound, but I'll send you the link for this as well in case you're interested. This is a study that was done by, it was done a while back. So when it was still okay to experiment on your college students for like $10. So we don't recommend that you try this at home. But this is important to note as far as, well, we're getting into seizures and what you'll find with seizures is that the difference between a seizure and syncope. So here you're going to note that there are these college students going in and they're being instructed to hold their breath for long enough that they pass out. They're creating their own vagal response type issue. So like it says here, induction of syncope. So we're not going to go over syncope too thoroughly today, but you can see this student is hyperventilating to the point that eventually his body will, when he stands up like this, his body just kind of freaks out. He's holding his breath now and he's going to pass out. So you can see it almost looks like he's having a seizure. He's not. This is a syncopal episode. So it's important to note that there are going to be times where you can't tell the difference, even you, if somebody's having a syncopal episode versus a seizure. If they have a history of seizures, that's incredibly indicative. But seizures are hard to diagnose even with a neurologist. Neurologists essentially diagnose somebody with seizures because they've tested for everything else and it's come back negative. And based on the description, they go, okay, yep, must be seizures probably. And then they give them something like Keppra. So you want to make sure that you're not treating one or the other. You need to be looking into both. So if you go to somebody's house and they are like, oh, my wife just collapsed on the floor and her whole body started shaking, do a full workup for either seizures or syncope, because you want to make sure that you've worked up both. So with a syncopal episode, there are so many different things that could be causing it. It's not just that they've just vagaled themselves out like these students here, but it could also be that they have some sort of arrhythmia with their heart. So this is another thing that you want to do a 12 lead for. Both of these are things that you want to take a blood sugar for. Stroke, also take a blood sugar. That's in your protocols, but also make sure that you're never forgetting to take a blood sugar. So there are all kinds of things that you need to be testing for in both areas. And we're going to go over seizures here, but I just wanted you to be aware. One of the most indicative things that something was a seizure rather than a syncopal episode is that postictal phase, which we'll talk about more. But not every person that has a seizure has a postictal phase. So make sure that you're taking everything into consideration. People that have this happen more than once in the span of a couple of minutes, it's probably more likely that it's a seizure than a syncopal episode, because how many people pass out repeatedly that quickly. So this continues on for a couple of minutes, but I think we've covered the points that need to be covered with it. So I sent it all over if anybody is interested in looking into it more. If I can get this, there we go. So these are the different types of seizures that You'll have pseudo seizures, which to me has always meant fake seizures, are not actually fake. They're just like they present similar to a seizure, but are not quite the same. So they they resemble seizures, and they're very similar, and they're associated with the same sort of presentation, but they're not actually technically a change in their electrical discharges in their brain. Um, that's not something. You don't have an EEG, you just have an EKG in your truck, so you're never going to know that in the field. So if somebody tells you that they have pseudo seizures, that does not mean that they are not having seizure-like activity. It does not mean that their seizure is fake. It just means that it's not originating from those electrical changes in the brain. You will, however, see fake seizures in your career. It's one of the most common things that people that are looking for medical attention but don't necessarily need it. It's one of the easiest things for them to go to because they see it on TV and it looks like a bunch of shaking and everybody gets all hyped up about it. And so somebody that's not in medicine but wants medical attention for some reason, one of the most frequently faked things you'll note will be seizure. Still work it up because you never know unless you know. So tonic-clonic seizures, you're gonna see these types of things are like showing in those tonic-clonic seizures. People that have them often may know what their aura is. Um, I One of the areas that I work in, we have a patient that his aura before he has a seizure tells him to go outside. His brain, his body, something in him he has this sudden urge to go outdoors. So he'll be at work and doing his job, and then all of a sudden it's like uncontrollably he wants to go outdoors. His coworkers know that if he just suddenly stands up from his desk and walks outside for no reason and doesn't communicate with anybody, they know to call 911 because he's most likely going to go have a seizure out at their picnic table. So that's one of the things that to ask about for somebody that has frequent things, but not everybody experiences all of these areas. Um, So the tonic-clonic is that you have these, it's the entire body changes in different areas. The clonic phase is the contraction of major muscle groups and the actual movement, whereas the tonic phase is usually more of that relaxed, like the collapse, the initial fall to the ground. Something to consider in tonic-clonic seizures is that there may be biting, teeth clenching, and these could be possibly issues for the airway. So you want to make sure, especially if they have that trismus, that locked jaw where you can't get anything to move in or out of their mouth, as far as like an OPA, you might want to consider an NPA if they're out of it enough that you're able to place that without them like fighting you. Even though NPAs don't cause a gag reflex, they're still not comfortable. Have any of you either ever tried to put an NPA in yourself or a friend? It probably didn't go super great. So um, if they're able to take it, an NPA may not be a bad idea if you're noticing a lot of that teeth clenching so that you can make sure that they're maintaining an open airway. Because teeth clenching, their tongue still has to go somewhere. So again, that tongue is that huge muscle that's, if they're not controlling it properly, well, it's contracting with this clonic phase as well as the teeth clenching. Now you have this possibility that you're going to lose your airway. After the seizure, this post-seizure phase, all of your major muscles are going to relax, and you may still notice some things like their eyes rolled back a little bit. Nystagmus, does anybody know what nystagmus is? Eye bouncing. That's a good description of it. So for anybody that's ever done any police type things, when they do like a field sobriety test and they have you follow their finger, and they go over to the side and your eyes kind of do that bouncing like Justin mentioned. That's nystagmus, and it's indicative in that particular scenario of somebody that's consumed a little too much alcohol, potentially. However, it's also possible for medical reasons, such as with a seizure. So when you have a seizure, you want to make sure that somebody's eyes, their pupils are equal and reactive to light and activity, right? So it's perla. And I know that I never really learned the A in my basic class, but that light is activity, accommodation. So when you make changes, are they able to follow your finger in the first place? And if they are and they do follow it, does it do any bouncing when you get to the far reaches? So after this post-seizure phase, you'll have the postictal phase. Again, not everybody has every phase of these seizures. Just like not everybody has an aura, not everybody has a postictal phase. So if somebody is not experiencing a postictal phase, they should still, you should still consider that it may have truly still been a seizure. During a postictal phase, if somebody is experiencing them, it can be as short as just a few minutes up to several hours. Uh, I don't know if there are studies on why or how long different presentations will have postictal phases. Um, it'd be something interesting to look into though. So during this postictal phase, patients are confused, they have trouble doing what they're told, they may be really tired. This is when they may continue to be incontinent. They may have already been incontinent during other phases of the seizure. Um, so they also may have difficulty communicating with you. So they may have a form of aphasia similar to somebody that was having a stroke. The difference being that it should resolve itself, whereas a stroke needs to intervention to be resolved, and that should be the only serious stroke-like symptom that they are experiencing. Um, Something that to consider too is that this just took a lot of energy. Everything that they've just gone through, their body has experienced, took a lot of energy. And where does energy come from? Your blood sugar, your glucose that's in your blood. So if you have taken a blood sugar because you think that they're having a seizure and there's a possibility that their low blood sugar caused the seizure, you also want to consider that their seizure caused their low blood sugar. Either way, if you have a low blood sugar, you want to make sure that you're giving them some form of glucose, like we discussed before. At the basic level, you could give oral glucose, but as you're moving, you guys are all moving towards the advanced level, you'll be able to start a line and give some D10. Or if you're not able to start a line, you can give, oh my goodness, I'm blanking on the name of it. It's the IM version. Um, Glucagon, thank you. So you can give the glucagon, you can drop 1 milligram of that, mix it into well, you're not going to drop a milligram of glucagon. You're going to drop a milliliter of saline, mix it with your milligram of glucagon. Or maybe it's a gram. It's a gram. And you're going to give that IM. This is your last resort. Your glucagon is your last resort if they can't follow direction enough to take that oral glucose, or if you can't get a line. And the reason for that is that D10 and oral glucose are both forms of sugar that you're putting into the body that the body can then immediately use once it's in the system. Glucagon is initiating a chain reaction essentially in your body, in which it's instructing your body to pull from your glucose stores and to change over the things that you've stored in different areas of your body and turn it back into glucose. If somebody is hypoglycemic often enough, they may not have those stores available. So if you give glucagon to somebody that is having these problems all the time, those stores are not, there's no storage in those stores. So it's not going to do anything for you. It also takes a little bit longer because again, it's the start of this process as opposed to just putting the systems together for them. So pseudo seizures, again, they're That does not mean that they're fake seizures, even though it sounds like it, and pseudo usually means fake. Um, they're a more generalized issue. It may seem exactly like a, any other seizure, but the root cause is psychiatric. Um, so it's not intentional, as it notes here. Um, it's You're going to notice that somebody that is having a pseudo seizure versus a tonic-clonic seizure, for example, is having all of their motions are at the same time. Like their left and their right arms are both shaking, but they're together. They're at the same time. When they have an outward rotation, they're both having outward rotation simultaneously, as opposed to like this left arm doing one thing while the right arm does something completely opposite. Um, if somebody is faking a seizure, they may be able to think to themselves that they want to do things more opposite, and so then it will present more like a tonic-clonic. Generally, if somebody's like their whole body is moving at the same time, um, that's that pseudo seizure. It's psychiatric, so it's not the same medical cause, but it is still a seizure that they are having, and it does still use that same energy that a tonic-clonic seizure would use. So again, you still want to make sure that you are checking their blood sugar. Absent seizures. So we talked about this. Is when it's really just like they stare off into space almost. Um, so they'll generally like, let's say you have like an ADHD 6-year-old that's just running around like crazy, and you think that they must have just run out of energy because they all of a sudden just stop dead and they just kind of stare off into space. Did they really stop dead and stare off into space because their attention was now grabbed by something inside of their own head and they're like sitting there thinking about something else? Or are they having an absent seizure? It's less likely that this is going to be a cause for 911 to be called because it might not be noticed. It might be very brief. Um, it's usually only a few seconds in the first place, but uh, it is possible that you will be called and they'll explain something that sounds like an absence seizure, and it should still be worked up fully in the hospital. So um, it could also be a precursor to worser seizures. So epileptic, where it's brought on by flashing lights or hyperventilation. These are also things that somebody that's having epileptic seizures may be triggered by. So it could be indicative that they will later develop into further and worser seizures. Focal seizures. So this is more where it's like in one specific area of the brain as opposed to kind of across the board. Um, so it can present very differently. In a status or a, excuse me, I'm looking at the next slide a little bit too. Um, in a tonic-clonic seizure, you're going to notice that it's their whole body and they lose awareness and they're going to have that postictal phase and all this. But a focal seizure can be just in one area of the brain, and so the rest of the brain could still be aware and able to respond to you, and um, they can present very differently, but it is still important. Um, some of the things that you may see, some signs and symptoms: lip smacking, eye blinking. Oh, it's written right there. Look at that. So you guys have that in front of you. They can also have like an uncontrollable fear, or they can start doing something over and over again. And they may not remember that they've done it. So they may not have that postictal phase where they can't communicate normally, but they still you may be like, hey, what happened 5 minutes ago? And they don't know because their brain just kind of like wiped it from their memory. Status epilepticus. So this is the one that's the most severe. So all of the other seizures, there's not an awful lot that can be done as far as if you were to call a medic. They're also going to start a line, and they're going to check a blood sugar, and they're going to work up to see if there was a possibility that this was it a seizure or was it a syncopal episode. These are the things that you can look into at your level. medic can look into at their level. Um, Status epilepticus, this is when you want a medic. Seizures that last more than 4 or 5 minutes, or these consecutive seizures that they don't have this return to responsiveness. Um, the definition of responsiveness can be a kind of personal thing that you decide on for yourself. For me, if I have a patient that is having multiple seizures and they're like sort of communicating, like they're making noises, like they're trying to say words between seizures, but those words don't make sense and we're not having a full conversation, I'm not going to consider that a full return to responsiveness. So I'm going to consider that potentially status epilepticus. Uh, at the medic level, you're more able to stop the seizure. The medic is more able to stop the seizure. So that's why you want to make sure that you call them quickly and early, get them there so that they can do what they need to, give the medications that those benzos that they're going to use to hopefully stop that seizure enough that they can at least make sure that everything else is good. Um, so some people say that status epilepticus doesn't, it's not truly status until there's been at least 30 minutes of seizure activity. As far as protocols and exams and everything are concerned, it's generally about 5. So you don't need to wait 30 minutes before you change anything or you start calling for that medic and you make those changes to ensure that they're getting treated appropriately. Um, this is another one that's so important to be looking at their blood sugar. If you don't have a medic available, but you are there and you're able to check a blood sugar and it's not doing so great, it's going to fall quickly because the body is working so hard to keep up with the demands to continue to have this much activity going on. So this is one, if you're able to get a line, which can be harder on somebody that is actively seizing naturally. You may take a couple of people, somebody to hold the arm flat and straight for you, and somebody else to place the IV. You want to make sure that you are bandaging it very well. This would be a good time to consider some like cling wrapped around it so that it doesn't fall out when they're moving around too much. And you're going to want most likely to consider a bag of D10. You're not going to want to run it too quickly. You're not going to like open it wide up and let it run the entire time that they're having these seizures. But if their blood sugar is low, you want to give it over time, similar to if you were running a bag of saline a little faster than TKO, but not insane, um, unless you've noted that their blood sugar is low, because they're going to need that glucose replaced. This is one that you want to get them there as quickly as possible. You also want to make sure that they're not doing anything additional to hurt themselves. This is true in any seizure, but generally with a regular tonic-clonic seizure, you're not going to note, they're not going to be having that seizure by the time you get there. But the amount of time that it takes for the 911 system to actually put out the tone and then for you to respond to the tone and actually arrive at the address, they're most likely not going to still be actively seizing. So in a general tonic-clonic seizure, you don't need to worry about that active replacement of glucose. You just need to make sure that they're not too low after you have arrived. But for this one, even though their blood sugar when you first take it might be 120, does not mean it's going to stay that high. So you want to make sure that you're prepared with that bag of D10. You're getting them there as quickly as possible, and you're making sure that they're not slamming into the sides of your stretcher. If you have a stretcher with the wings, this is not a bad opportunity to use those because they are a little bit more like there's less likely that an arm's going to get caught underneath the side of the bar while they're throwing their body all around. So it's a little bit safer, but if you have additional blankets, pillows, anything like that that you can shove along the side of the stretcher, in between the patient and those bars. I know if you go into the hospital, first and foremost, give them a warning when you're coming in with a seizure patient so that they can make sure that they have the appropriate equipment there. But you'll see that they have like, usually they're blue, the padding that they attach to the frame of the bed, and that's on any seizure patient so that if they hit, they are not hitting the hard metal. There's some form of padding there. So if you can also create padding, yours is not going to be quite as official, quite as stable as what's available at the hospital, because we just don't have the space in an ambulance to carry every piece of equipment possible. But if you have those extra blankets, those pillows, anything like that that you can shove in there, um, make sure that they're not hurting themselves any extra. Again, glucose, also ABCs. All of their muscles are firing in a way that they don't have control over. That includes their tongue. So again, airway, breathing. And this is another case that not just starting a regular medic, but potentially starting an RSI medic, because there are some cases of status seizures that are not being solved by benzos. It's not super common, but for those that work in the action coverage area, we used to have one on Route 25 in Tamworth that would go through every bit of benzos that were available and still be seizing. So that's when you want to consider whether you want to call an RSI medic so that they can take control of that airway. Regardless of how much glucose you put into a person's body while they're seizing, and making sure that they're maintaining their glucose, if they're not breathing, it's not going to help them at all. So common causes of seizures. You have congenital disorders, diabetic emergencies, like we talked about, fevers in infants. Fever, you'll notice that it says the rapid rate of rise. So it's not just somebody that has 103 fever, it's somebody that had a 98.6 temperature 5 minutes ago and now is 103, and it came on so quickly that their body just didn't know what to do about it. So it caused that quick change. Epileptic seizures can be controlled with medications. So if somebody is taking a seizure medication, most common being that Keppra, and you ask them if they've been taking their medication normally, and they say, "Oh yeah, no, I forgot yesterday," that can be a huge reason for their seizure, because if they don't take that prescribed dose on a regular basis, they're going to be causing that issue. So most seizures are a result of medication noncompliance. If they tell you that they've been taking it normally, regularly, every single day, they're reliable, they're 100% on it with their meds, make sure that they go. They should go even if they forgot their medication for a day, because it sometimes takes a little while to get back on track and get your body back to being fully regulated, and it may need an increase in medication dosage for a day or two or something like that. And that's not up to the patient or to you to determine, that's up to a doctor. But if they continue to take their medication normally and still have the seizure, why are they having a breakthrough seizure? There's either something else wrong or that dose is not adequate. Both very important things to find out sooner rather than later. So, importance of recognizing seizures. You need to be able to tell, as far as anybody can, when a seizure is occurring or has occurred. It's also important to note if there's somebody that has a history of seizures, was this one similar to other ones, or was it different? If it was different, how did it differ? Making sure that they are not having any complications. That's the breathing, that's the blood sugar that's now in the toilet. And have they been incontinent? So sometimes if I am unsure if somebody's truly had a seizure or not, but they've peed their pants, chances are they've truly had a seizure. Unless you're really committed to faking it out for everybody in the room, most people don't pee their pants when they're having a fake seizure. That's some true commitment. And you know what, dude? We'll bring you to the hospital because you earned it. So somebody that's bit their tongue, make sure that you're checking, because again, they have that clenched jaw, that trismus type activity. but they also don't have the control of their tongue that they normally do. So you want to make sure that you're checking in the oral cavity to make sure that there's not a buildup of blood from them having bitten their tongue. You also want to make sure that if they did bite their tongue and there is blood in there, that you are checking to make sure that their tongue is still whole. Did they bite off the tip? If they bit off the tip of their tongue, is it still in their airway, or did they spit it out? I don't think it could be reattached, but I'm not a surgeon, so I don't know. But bring it in just in case. But you want to find it, because if it's not on the floor next to them, then where is it? Have they swallowed it? Is it in their airway? If it's in their airway, suction. So looking again at the postictal state. So in addition to their mental status being a little bit harder for them to communicate with you and things like that, you also may note that their muscles relax so incredibly that it's almost like they've passed out right now. You want to make sure, for those of you, I don't think I ever learned it in my basic class. So a cool trick, if you're trying to pick somebody up off the floor that you don't have like a good grip on, and they're not conscious enough to maintain their muscle stressing and everything in the right spots to make sure you don't drop them if you grab them under their arms. So you're going to reach underneath their underarms and grab their wrists so that their arms are bent like chicken wings. And when you lift them up, even if they like lose consciousness, and you want to grab the opposite wrist. So that way, even if they lose consciousness, they're not going to like slip right, their arms won't go flaccid and just like slip right through you. You'll be able to have that hold on them still. So somebody that's postictal, if you're lifting them to the stretcher with under their arms and under their knees, for example, if there's just two of you, try and grab those wrists, even if they're conscious right now and they're answering to you. Just be prepared in case their body just goes, no, you know what, we're tired, and doesn't feel like helping you along. Things that if their conditions don't improve, you want to consider those underlying conditions. Again, we've talked a lot about hypoglycemia at this point. Hopefully all of you know by now that blood sugar is like a baseline vital for any neurological issue. I wish I could say that it's a baseline vital for any call ever, but I would be lying because I do not take it on every call. But it's something that should be considered on every single call. Also, infection. Infection can cause all kinds of things throughout the body, including potentially seizures. And so if they're still having those effects far longer, it could possibly be related to infection. So that's the end of seizures. Does anybody have any seizure-related questions? I will also accept stroke-related questions since we're through that section. Getting some no's. All right, we're going to move right into altered mental status before we take a break, because there's only 2 slides for that, so we should be able to whip through it pretty quickly. So altered mental status, it's defined as a patient who is not thinking clearly or who is incapable of being aroused. So this is not just unresponsive, but also responsive but confused. I did just read the entire slide to you. I apologize. Causes, you're going to have all kinds of causes. They're listed here primarily, but there's also drug overdose is not listed there, I don't think. Oh, there's drug intoxication. Brain tumors, abnormalities, poisonings, things like these can all cause altered mental status. We've talked an awful lot about hypoglycemia, but again, that can cause altered mental status. It's one of those types of calls that you want to make sure that it's one of your baseline vitals. The primary difference in a patient who has experienced a stroke is that they may be, a patient that's experienced a stroke may be alert and they're trying to communicate normally and they're just not able to. But a patient with hypoglycemia is going to have an altered mental status generally. That's not 100% of the time. So if you have somebody that's presenting with a stroke-like symptoms, you should still take a glucose level. But altered mental status is generally more indicative of hypoglycemia than it is stroke. Patients with a decreased level of consciousness may not be able to adequately protect their airways. So with altered mental status, you want to make sure that you're prepared and ready in case they do become altered enough that they forget to hold their tongue out of the way or forget to keep their mouth open while they have a really stuffed up nose or something along those lines that's going to cause an issue with their breathing. This could be an unrecognized head injury. So if you go into a nursing home and they tell you that the patient that you're bringing out fell 3 weeks ago and they've been acting slightly more and more confused over those 3 weeks, that's important. It may have been slow, but the bleed that's happening inside of their brain may have also been slow. That altered mental status that's been building over a while could still be a result of that unrecognized head injury. So infections, you're going to find that infections can cause this altered mental status. You should think of sepsis as one of them. Sepsis is generally a single infection or multiple infections that have gotten so progressively worse that they have now infected the bloodstream and are traveling throughout the entire body. So any infection can become septic. If somebody tells you that they got a splinter 3 weeks ago and they're now having altered mental status, and you look at their finger where they had the splinter and it's like kind of oozy, you're going to want to be like, a splinter caused your brain to be all messed up? Yes. If their finger got infected enough that it traveled to the bloodstream and it's traveling now throughout the bloodstream, that patient's altered mental status could be due to the infection that started with their splinter. So something that you want to consider is also infections that haven't been noticed yet. This patient that's been, again, at the nursing home and they've been progressively getting more confused for the past 3 weeks and nobody really knows why. If they did not have a fall 3 weeks ago, that could be a slow brain bleed. But maybe their urine output has changed. Is that a UTI that hasn't been caught yet and has now traveled into the bloodstream and is causing a septic reaction? I'm not gonna lie and tell you that I understand why. Call a sepsis alert. I don't really know what it changes on the hospital side. Kevin would probably be better to answer that if you guys have questions about why a sepsis alert is important. But if you're having altered mental status along with enough other indications for sepsis, call that sepsis alert. My understanding is that the only major difference when you get to the hospital is that they're going to draw a different kind of lab. They're going to look at the lactic as well as their regular labs. Tandra, I'm sorry if I just completely botched that. You worked in the hospital, right? I know you were not direct patient care, but do you have any insight on why a sepsis alert is important if you're there? I know you were driving before, so. Oh, she left. She ran away. She didn't want to answer the question. So does anybody else work in a hospital that may have any insight on why a sepsis alert is important for us? Because I genuinely don't know. We were actually talking about it at work the other day, and somebody said they think it's so that certain things can happen quickly enough that they can bill for Medicare, which is possible. So in addition to altered mental status, as far as if it's an infection, if it's a bloodborne infection and therefore likely considered sepsis, you're also going to notice other signs and symptoms. So I am going to pull up the protocol so that I don't give you the wrong things. But when you look at your protocol in New Hampshire, It's 2.19a. You're going to look for at least 2 or more of the evidence of sepsis criteria. And those include a temperature that's too low or too high, a heart rate that's greater than 90, respiratory rate that's greater than 20, a MAP of less than 65, or a systolic blood pressure less than 90, and then an end tidal less than 25. Serum lactate level is one of the things that they're going to do if you call that sepsis alert. And then that new onset of altered mental status or increasing mental status change. So altered mental status, you're going to look at all of these things, but one of the primary things that could kill somebody quickly is sepsis, because somebody can appear with a heart rate of 92 and an altered mental status, a slightly altered mental status, and an hour later they could be so septic that it's hard for them to come back from it because they lead into septic shock. Have you guys gone over shocks yet? I don't know what order the class is running in. Yes, so then you know that you have like compensated, decompensated, and then irreversible shock. So sepsis is a shock in and of itself. So altered mental status, that's one of the things that you walk into an altered mental status call, make sure that you're looking at your sepsis protocols. Because if they are in a septic shock, right now it may be compensated, but you don't want to let it get to irreversible if you can avoid it.
Laurel?
Really, the only thing that you can do for sepsis is fluids.
Laurel, it's Tandra.
Any questions on altered mental status? There are other causes for it. I have them in front of you, but if anybody has any questions, if we didn't cover any of those enough, let me know before we move on. Is everybody else here? I get a couple of you guys saying no every time, but
Laurel, can you hear me?
you 3 get extra credit. No, I'm just kidding. All right, I'm seeing a few more names popping up, so at least I'm not boring you all into nap time. Thank you
Laurel,
all for
can you hear me?
letting me know your presence. So syncope, and we just went over that video.
Laurel?
I didn't think that, Rosa, is that you can hear or cannot hear? You must be bored out of your mind if you can't hear.
Laurel, can you hear me?
People are calling to me. I am not hearing them. I don't know why I can't hear them. Do I have this muted?
Laurel, can you hear me now? Tandra, can you hear me?
I have my volume up.
Okay.
Has anybody had questions that they've tried to verbalize and I've ignored them because I cannot hear anybody else speaking. And I apologize if I've seemed like I was ignoring your questions. I don't. Oh, for anybody that's not currently in the chat section, Tandra, and I'm so sorry again if I'm pronouncing that terribly, did get back to us with her sepsis alert answer. It lets the hospital get the necessary resource to the ER to wait for the patient instead of the patient waiting for the resources and staff. Okay. Other than they're lactic, I don't know what other resources there are, but I haven't worked in the hospital side, so there may be something else that's critical that's going on. All right. So if anybody does have any questions and they've tried to say them, they've unmuted themselves or anything like that, please put them into the chat if you can, because I'm not hearing people. Or if somebody else notices somebody speaking, let me know. I'm not trying to ignore you, but we'll move into syncope because I don't think anybody had any questions on altered mental status. So syncope is fainting, and it can be a sign of a bunch of different things. So syncope doesn't just happen. It can be caused by a vagal issue, so the vagus nerve. If you are causing an issue with the vagus nerve that it's being compressed or changed and your body doesn't know what to do about it, it will cause you to pass out. So when you have Granny on the floor next to her toilet and you ask her if she was straining to have a bowel movement and she says yes, she may have caused an issue with her vagus nerve. And she vasovagaled and caused that syncope. However, that being a pretty benign finding, vagus nerve issues, is not the only reason that people have syncope. So one of the things that you want to do as quickly as possible for anybody that's passed out is a 12 lead. They could have a cardiac dysrhythmia that isn't constant. You might see it when you're there on scene, and by the time you get to the hospital, it may have resolved. So make sure that you're getting those 12 leads as quickly as possible. In a cardiac issue, like if you're called for chest pain, I don't know if it's across the board, but I've always heard that the expectation is that a 12 lead is completed within 10 minutes of your arrival on scene. It should be even faster than that, but we give a little bit of leeway because sometimes it's just not physically possible to get to a position that you can put a 12 lead on somebody as quickly, but also for syncope, try to be within those 10 minutes, just the same way. There we go. So some potential causes, like we talked about, the cardiac rhythm issue, cardiac muscle also. So if you can listen to heart sounds, I'll be honest, I don't listen to heart sounds often enough to be able to say very definitively that it sounds wrong. Unless it's blatantly wrong, I can't always tell. So MI, that's another. So again, even though they're not having chest pain, that fact that they had syncope could be indicative. That could be the only sign or symptom that you see of that MI. Women present very differently from men when they're having MIs. They don't generally, like men, you usually hear that they had crushing chest pain on the left side. It was shooting down their left arm. Women might have some abdominal pain, and that's the only sign or symptom that they're having an MI. They could have passed out, and that could be the only sign or symptom that they're having an MI. Dehydration, so you can check for tenting at the hand, see if their skin does the tenting, and that's indicative of that change, that dehydration. And the solution to that can be fluids. Hypoglycemia, again, always try and check for a glucose level, unless it's like that really cut and dry, like run to the hospital. And that vasovagal episode, so like we talked about, somebody that's just really straining on the toilet. So we're getting close to another hour that we've been working through things. We have just under 20 slides left. So if you guys want to take another 5 or 10 minutes, let's be back at 8. So that's cuts it right in the middle between 5 and 10. So I have 7:53 right now. We'll start again at 8. If you guys want to take a few minutes. If anybody has any questions on anything we've covered so far, please throw them in the chat because I can't hear you.
This conference will now be recorded.
Oh, it just announced that it's recording. It hasn't done that any of the other times. I can hear you guys now. Thank you to one of the Matts. Sorry, Matt, I don't know your last name, for fixing that for me. So we are going to move into
Welcome.
headaches. So there are a few different types of headaches. You'll notice a couple on the screen. These are the most common. They're generally not life-threatening unless somebody says it's the worst headache of their entire life, and then they have other signs of stroke. Then their headache is life-threatening. Speaking of strokes, and not to go back to something we haven't covered, but something that I learned in the field more than in class and is very useful information is if you have a stroke patient that you're extricating from the house, bringing to the hospital, that kind of stuff, you want to try and make sure that you're keeping them at a 45-degree angle because you don't know for sure if it's which kind of stroke it is. If you're like sure that you know, and you want to keep them based on which kind of stroke you think it is, that's on you. But generally, a 45-degree angle, that keeps it so that it's the path of least resistance for the blood without making it so no lack of resistance that they're bleeding out into their head. So a 45-degree angle is the goal. Anyway, back to headaches. So tension headaches can be caused by residual muscle contractions within the face and head, and they're usually attributed to stress or tension, altered cortisol levels, and/or depression. The pain is usually described as squeezing, dull, or as an ache. Migraine headaches can be caused by instability within clusters of neurons, but they can also be changes in the blood vessel size at the base of the brain. So these patients can experience an aura, similar to some patients that are about to have a seizure. So people that have migraines often may tell you that they're experiencing their aura and they know a migraine is coming on. Patients that have dogs that are trained for their migraines may be able to sense their aura. I've never actually seen that in the field, but I've read about it. Sounds really cool. I don't know how you train a dog to do half the things that dogs can do. It's amazing. So they may experience an aura. Migraines may be a focused pain that spreads over time. And they can describe it as throbbing, pounding, pulsating. They may have nausea or vomiting. Generally, these patients are going to prefer dark and quiet environments, and they can last for several days. So if you're transporting a patient that's having a migraine, something to consider is turning the lights down as low as you can. You never want to turn the lights all the way off in the back of an ambulance because your partner can no longer see you through your little rearview mirror. So if you're being accused of anything untoward being done and all the lights were off, that's not a great look for you. At least leave the workstation light on, something that I was taught. But if you have a patient with a migraine and you're keeping lights on so that you can do what you need to do, throw a towel or something over their eyes as long as they're good with it. If they are terrified of small spaces or something like that, they're going to feel claustrophobic. They may opt out of that. They may decide that they'd rather deal with the light than deal with something over their face. But if you have the option to place a towel or something over their eyes, that can be very helpful. Then cluster headaches are a vascular type of headache that occurs in groups. They usually last 30 to 45 minutes, and a person could have several all in the same day. They may occur for days at a time, not all at once. Like a migraine just lasts for several days, whereas cluster headaches may occur multiple times in a day for several days, and they're usually lasting for that 30 to 45 minutes each. And it starts as a minor pain that starts around one eye generally intensifies and then spreads. Again, none of these are, this is always the textbook definition. If it doesn't present like this, it's not that, but generally it starts as a minor pain, one eye, intensifies and spreads. They're also going to feel kind of anxious, because who wouldn't feel anxious if it felt like your eye was like throbbing and then all of a sudden it spread to your entire brain. And then not on your slide, but another relatively common headache is sinus headaches. They're caused by inflammation or infection within the sinus cavities of the face. And you may find that you have some pain in the superior portions of the face that increase when you're bending forward. So if you ever were to look at what map of the sinuses was, you would see that it does go, here we go, map of sinuses. It's all in the higher part of the face. So when you have a sinus headache, it may be a headache in general, but it's usually going to be like in the front of the head and kind of underneath the eyes here. Oh, I didn't know it would do that. All right, so there's headaches, and then patient assessment. So like we talked about at the very beginning, your patient assessment is very important. You're still going to check your ABCs. You're going to check that glucose level as a baseline vital, because those things that you can catch, the things that are leading to their seizure or are leading to a continuation of their issues that are being caused by this initial neurologic change. If you can fix them faster, time is brain. So your brain is the organ that's the most sensitive to changing levels of anything going on in your body, but especially oxygen, glucose, and temperature. So one of the key things that you're going to find is like looking for those subtle changes. So like we talked about with the stroke patient, that all he had was that feeling like his hand was asleep. That was a whole stroke. So making sure that you're paying attention to even those subtle changes. And that's going to be, you're going to note that in like your head to toe assessment. When you do a stroke exam, you'll want to find even those very subtle things. While we're on patient assessment, I also want to mention for you guys, there is an app that you may want to consider to having on hand. It's specifically helpful for strokes, but it's called Join Triage. If you go into, let's see if I'm logged in. So if you are not logged in, there is a free version. I'm going to turn on my camera and you're all not going to make fun of me for my red face. So you'll see on here, this is my Join Triage app, and you can see that it has all kinds of different things that you can go into. If you choose to do the free version and you don't want to log in, you can just pop onto Join Triage and you can pick Fast ED, and it will bring you through ask to find out if a patient is having a stroke. So it's asking me, is the patient on anticoagulant and blood thinners? I'm going to say that they are. And what time were they last seen well? And I'm going to say it's unknown. Do they have facial weakness? And we'll say that they do. And they will say that they have some mild arm weakness, but their speech is normal. And when you ask them to show you 2 fingers, they can do it. There's some gaze preference. Are they weak anywhere? They say no, and they're right. When you ask the patient, whose arm is this? And you point out their own weak arm, can they tell that it's their arm? So if I've answered all those questions, and I just made up, I don't even remember now which ones I picked, but it will tell you at the end your score. So this patient has a 3, which means that there's less than a 30% chance that they're actually having a stroke based on the things that I gave them. This way, if I've forgotten to ask certain questions, this is going to prompt me to do so. It's also going to go in and tell me how probable it is. So when I call the hospital, I can say, hey, I have a FAST-ED stroke scale score of 3. And they may not know which things have caused that score, but they do know that they can that it is or is not serious. So this is join triage. I'll write it in here. It is free, even if you sign up. And if you sign up and you wanted different versions, you have, like, this is J Arato, and I don't use this one, but if you went in, it's asking you questions again. And this one's asking me about my respiratory rate, my body temperature. So there are different ones. You can play around with it, see if you are interested in anything other than the FAST-ED. The FAST-ED is definitely the most likely to be useful to you in the field for strokes, but it's free to sign up and have all of it. So, and all those different scales, they're not all just stroke. It can tell you all kinds of things. So it can be like there's national trauma activation criteria. So you can go in and see if they meet trauma activation criteria. It's a good assessment tool for you. I used to have also for patient assessment, like a little thing that fit in my wallet, like that size sheet that had questions that you could ask that got a more in-depth neurological assessment than just the typical stroke scale. But I lost it. So I wish I had it because I could go over the questions with you guys. But one of the downsides of taking things out on scenes is sometimes they then live there forever. So scene size up, just like in BLS, you're gonna scene safe BSI. You want to consider where your closest stroke center is. Like it says, if it's more than an hour away, you want to consider calling for a helicopter because that hour, time is brain, is sometimes, I know they've changed how quickly now you have to get patients to the hospital before they can or cannot give their medications. So if you're trying to get the TPA or the TNK or something like that, it used to be that you only had an hour. If they had been acting normal 2 hours ago, they couldn't really do much. And the reason for that is that the TPA is like a clot buster. So if the clot's been there for too long, it's going to take such a large dose to bust it up that you're going to potentially bust up other clots also. So included in your assessment, you also want to find out about any other falls or injuries that a stroke patient has had recently. Because if they fell down and they have a bruise on their hip, it looks like it's like an all right bruise, but it's still noticeable and it's there. They may not be eligible for the medication that's going to fix their stroke because when they break up the clot that's causing the stroke, they may also break up the clot that is holding that hip from continuing to bleed. That's not up to you guys to decide. That'll be up to the hospital, so you don't need to worry about knowing how severe any injuries need to be or anything like that. But it is something to consider as far as where the closest, not just stroke center as far as somebody that can give that medication, but there are now ways that strokes can be treated where they'll almost like the balloon pumps for if you're having an MI, they're going to go in and they can almost like grab the clot out of the person's brain. I haven't seen it done. I don't know much more about it, but it sounds really cool. So you want to make sure that you know how long the patient's been down for, and where your closest stroke center is. Again, you're not going to bypass your local hospital that can give TPA, because the hospital that's farther away can like go in and pull the clot out, because it's you guys are not the ones deciding if that's the necessary treatment. So um my computer's not working. There we go. So your primary survey, you're gonna form your general impression. You're gonna look for things like posturing. Does anybody know the two different types of postures that we're seeing here? Which one's which? All right,
Left
yeah.
side, I think, is decerebrate, and right side is decorticate.
It's actually the other way around. So decorticate is when they pull in towards the center, and decerebrate is when they extend out. So yes, I see somebody has decorticate on the left and decerebrate on the right. So yeah, decorticate has the word core in it, so that's how I remember it. I see somebody else remembers it that way as well. It's to the core, and then decerebrate doesn't have core in it, so it's not towards the core. So that is indicative of severe brain dysfunction. So somebody that's had a brain injury that is having decerebrate posturing is very, very bad off. Somebody that's having decorticate posturing is still not doing too great, but at least not quite as bad. You will sometimes find patients that have like a little bit of both, almost like they're at that borderline position between decorticate and decerebrate. And that's just they're in between. So you want to also determine their level of consciousness. If the seizure is still in progress, you want to watch for a potentially life-threatening condition, such as that hypoglycemia that's so severe that you need to start like hanging that D10. Or if it's status epilepticus, you want to consider calling for that medic if they're available. So you want to focus on your ABCs, because that's always going to be your focus. ABCs are the baseline of EMS, right after scene safe BSI. You want to make sure that the airway is patent. You want to make sure that you have suction ready, because these patients don't always have control of all of their normal things that their body does. So if the brain is, we talked about earlier, the brain helps with even the things that you don't think about: heartbeat, 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 breathe, heartbeat, 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 breathe. Also, swallowing all that spit that your mouth has created. How many times throughout the day do you think to yourself, I'm going to swallow my spit? Not super often, unless you're chewing tobacco or something like that, and then maybe you're thinking about it all the time. But you're still doing it without even really thinking of it. But when you have something that's going on with your brain may no longer have the capacity to tell you to swallow your spit. So even if they don't currently look like they're going to need suction, you should have it available. If you're going in for somebody with altered mental status, and this is something that everybody fails at across the board, there are very few people that I can think of that are genuinely good at bringing in their suction on any altered mental status, stroke, seizure, anything like that call. Generally, people bring it in for their codes, but other than that, it's not always your first thing that you grab. But it should be for any sort of potentially neurologic issue, because the brain could have stopped telling the body to swallow, and you need to get it out of the airway some way so that they don't aspirate, because if they're not swallowing, they're probably also not being able to maintain that division between what's supposed to go through the lungs and what's supposed to go to the stomach. So naturally, if no pulse is found, immediately begin CPR. And that's true with any kind of emergency. So you want to consider your OPAs and your NPAs if you're providing ventilatory support. like we talked about before, you may end up providing that ventilatory support at slightly increased rates if their end tidal is higher. Have you guys gone over end tidal very much yet as far as what numbers you're looking for and what controls? I know you went over some acid-base stuff, and that's pretty related to acid-base extensively. Okay, good. So you know that if you're increasing your respiratory rate, then hopefully you're decreasing your end tidal. So if your end tidal is not between that 35 to 45, if you're thinking that it's a brain injury or there's some sort of swelling or anything in the brain and you want to move more towards that 35 and go ahead and increase from that 10 to 12. Obviously, don't do anything too crazy. Generally, you're looking for 6 breaths a minute, or every 6 seconds, so that's the 10 breaths a minute. But if you need to change that based on your end tidal readings and the other presentations that you're noting, that's not a hard and set rule. So you want to make sure that if you're giving oxygen, you're not doing anything too crazy. You want to maintain an SpO2 greater than 94, but you don't want to hit 100 if you can avoid it, because it doesn't measure that it's 102%, and then you end up with your free radicals, which can cause further issues. We won't get too crazy into free radicals at the moment, because you probably don't care too much. It's just a cool thing to say, free radicals. So things that you can see that are evidence of increased ICP during this primary survey is increases in blood pressure, decreases in heart rate, irregularities with the respiratory rate. You guys are probably familiar with the different respiratory patterns. I know there were points in classes that I've taken that have gone over. You had to listen to all the different respiratory patterns, like the Cheyenne-Stokes, which is usually ketoacidosis, I believe. Basically, once you're done with school and you're done with your testing, your respiratory rates are irregular is going to just be like they're breathing and it's weird. And if you don't know that it's called Cheyenne-Stokes, you don't know. But you should know generally like what the different types mean. So like that quick, fast, shallow breaths is indicative of one thing, whereas those very slow, deep breaths are indicative of something else. So you want to know that. So when you have the Cushing reflex, that is the opposite of shock. So that's that blood pressure increases, heart rate decreases, respiratory rates are irregular, and the pulse pressure widens. So that is Cushing's reflex. You can also look at Cushing's triad, and those are indicative of that ICP. And can you Google it in the back of a truck? Yes, I've done it. Somebody's vitals looked really, really weird. I thought they might have hit their head. I Googled Cushing's triad because I'm going to be honest, there are so many triads and so many things that you have to know that occasionally you have to Google them in the back of your truck and do what you need to do to make sure that the patient's being treated. So your transport decision. You're going to make sure that your unstable patients naturally are being transported immediately, because there's only so much that you can do on scene. It's definitely been a change. When EMS was obviously first created, it was throwing people in the back of a hearse and driving them to the hospital. We have advanced enormously since then. You now have almost a whole ER room in the back of your truck. So it's not always the case that you need to drive that quickly. For your safety and the patient's safety and the safety of everybody on the road, any treatment that you can administer that's going to stabilize the patient should be done when possible. Do it in the driveway if that's what you need to do. Where you guys are going to be new A's, you're probably not going to be super, super great at IVs yet. That's okay. Nobody's great their first try. Do it in the driveway. Don't try and do it down the bumping road. Even if I have somebody that I think is going to be a tough stick, or that looks like I just don't want to stab them more than once because they're nervous of needles or something like that, If we're already driving, by the time I find the vein that I want to go with, I'll have my driver pull over. Do what you need to do to make sure that the treatment is being administered safely. You are getting closer and closer to being at the point where you're essentially the doctor in the field to an extent. So make sure that you're treating the patient accordingly. If all they need is fluids to become stable, don't run to the hospital lights and sirens and make it unsafe for everybody. Make sure that you're giving that treatment when you can. If they're unstable or deteriorating quickly, naturally, that one's when you're going to want to transport rapidly to the closest, most appropriate facility. You want to focus on stabilizing and maintaining your ABCs. You want to make sure that you're rapidly recognizing and transporting to the appropriate facility. While somebody with hypoglycemia can be fixed on scene, you don't need to run lights and sirens anymore for that person. Like at the basic level, that person that's not conscious and their blood sugar is 20, you got to run. At the advanced level, you can start that line, you can give that D10, you can fix the majority of the life-threatening problem right there on scene. However, you need to also be able to recognize when you can't and make sure that you're choosing the appropriate facility, because changes to the brain can be permanent, and they happen quickly, and time is brain. You want to give as much notice as possible if you're bringing in certain things. So we talked about sepsis alerts, we talked about stroke alerts. You want to make sure that you are aware of when the last time that they were seen normal was. If they were having a seizure, how long did it last? Was it just their left arm or was it their whole body? When do you think you're going to arrive at the hospital? These are all things that you should be letting the hospital know as soon as you know them. If that means that you know that you're not going to have reception, you're not going to have cell service for the next 15 minutes, but you have it right now on scene, take that extra minute on scene and call the hospital and let them know you're coming. It's an extra minute that, yes, you could be transporting, but that extra minute is only 1 minute in the field, and it's going to save 15 minutes at the hospital of them trying to get all their stuff together and making sure that they're ready for you. So history taking, you're gonna check out your chief complaint. So I'm sure that you are familiar with your head to toe assessments, trauma assessment from your basic practical exams. And then when you get into your medical exams, sometimes that's more, you can kind of pinpoint that this is the area that they're complaining of, but you still want to make sure that you're doing a full assessment. So yeah, you walk in and somebody says that they're having abdominal pain. You're going to check out the abdomen. You're going to palpate the 4 quadrants, but that doesn't mean that you shouldn't do a 12 lead. So for somebody that's having any sort of neurologic issue, just because you can say, oh, I know it's a neurologic issue, I'm going to focus in on this, doesn't mean that you should ignore that blood sugar, that 12 lead, those other things that could be causing it to worsen. So you can kind of focus in, but don't focus in so much that you miss some of those big things. If they're unresponsive, you're going to gather as much information as you can from the family or bystanders. If they're unresponsive and they're critical and you're trying to go and you think it's a stroke, like I said before, bring a family member with you if you can. If they're able to tell you more about the patient on the way, or if they're able to tell the hospital staff about the patient and what happened and how long it took and all that, it can change the patient's treatment enormously. Because the difference between the stroke starting at 5:30 a.m. versus 6:30 p.m. when you go and pick them up at 7 a.m. is enormous, and you don't know that, but the patient's family may. So you want to look for explanations of altered mental status if they're having it when you're doing the history. So you're going to ask about trauma. You're going to look for trauma, signs of trauma, bruising, active bleeding, things like that. You're going to look for medical alert tags. Somebody that has type 2 diabetes may be wearing one of those alert bracelets. could be important for you to know. Hopefully you'll think for altered mental status to check for blood sugar anyway, but it can be a good reminder. You also want to look for track marks. We're all familiar. I'm sure that it's seen everywhere. Doesn't matter what kind of area you think you're working in, check for track marks if there's any chance. Just because they don't fit the typical presentation of somebody that is a user does not mean that they are not a user. So it could be the reason for their altered mental status. So you're also going to look for just general environmental clues. This is part of your history taking. If you ask the patient if they've been drinking and they say no, but you look to your left and there are 6 empty liter bottles of tequila, what are the chances that they truly have not been drinking? It's still possible, but if they're that frequent of a drinker that they have that many empty bottles, chances are there is some alcohol. So that's part of your history taking because the patient's not always going to be honest with you. If they've had a seizure, you're going to make sure, like I said, check in the mouth, make sure that they're not bleeding into their airway. See if they've had any sort of incontinence because it helps you determine care as far as, yes, I definitely did have a seizure versus maybe it was a syncopal episode. Although people can also be incontinent with syncopal episodes, so even that is not definitively indicative. If the patient has a headache, try to determine their level of stress, their possible infections, and their histories of headaches. So that's part of your history that you're going to look into. You want the full sample history whenever you can. So if the patient's not able to communicate with you, you can try to get that information from somebody else in the house. The list of medications can be very useful, like we talked about, if they're taking an anti-seizure medication, but they didn't take it yesterday. That's very important information. So make sure that you're grabbing that with your history. When you get to your M's and you're looking at medications, don't just ask what they take, but ask if they actually take it reliably. Even patients that can't communicate with you, like we discussed with the videos that I sent out initially to you guys with the different types of aphasia, you have patients that may not be able to communicate with you, but they can still hear and understand everything that's going on around them. So try to make sure that you're still establishing some sort of effective communication. Sometimes patients that can't speak can still write it down what they're thinking if that's an option for you. It's not always a bad one if that's the only way that you can communicate with them. But also just make sure that you're communicating what you're doing. Just because they can't say, okay, yes, it's all right for you to do an IV, because they can't speak to you, doesn't mean that their brain isn't still processing that you're about to stab them and you should give them a warning. Try to explain your way through any procedures that you're doing. And again, you want to make sure that you find out if this is different, if this is something that they experience often, is this different from previous times that they've had the issue. If they do not have a history of whatever's going on, then the condition should be considered more serious. So if they've never had a seizure before in their life, this is the first one, that could potentially be more serious of a condition than somebody that has had a history of seizures and missed their Keppra yesterday. So your secondary assessment, you want to perform this as quickly as possible. So again, thinking about your practical stations for EMT, your trauma station. Sometimes you're going in, you're doing your initial assessment where you decided that this was a critical patient and you were going to transport rapidly to the closest appropriate center. So that was your primary assessment. You walked in, you were like, they're breathing or they're not breathing, we're going to bag them. This is a serious patient, so on and so forth. And then your secondary assessment is that full head to toe. So like we talked about, you don't always have to do full head to toe for a medical patient if they're able to communicate with you what's going on. But you should still take a quick look as much as you can. This is not going to be, we're going to cut off all your clothes and see if you broke your ankle if they're coming in and telling you that they're having the worst headache of their life, unless they fell due to their headache, because that worst headache is a stroke and they lost control of their body and they fell. Generally, you're going to be able to kind of keep it a little bit more regionalized to neurologic issues, but that doesn't mean that you want to miss out on testing their arm movement, because that worst headache of their life, that could be just a headache, could also, again, be a stroke. And when you go and check their arm movement, you're going to notice that it's not equal. And that might be the worst headache of their life, and the unequal arm movement might be the only signs and symptoms that you see. So yes, you can narrow it down to a more detailed certain exam, but don't miss the things that are related. So other stroke assessment tools are the Cincinnati and the Los Angeles. Both of them are pre-hospital stroke scales, and you can choose whichever stroke scale is best for you, but I know a lot of hospitals are moving to that FAST-ED. They're using that joint triage or like that list of questions, but if you use that joint triage and you can give them a full scale with the score, that can be very helpful. So it's telling me that I should point you to table 19-6 in your textbook if you're interested, and that's a checklist that will help focus on gathering information that the emergency department physician will need before administration of the medications can be considered. So that's definitely an important checklist to be familiar with. I don't have it in front of me, but I would take a look at that when you guys have a minute. I don't have a page number for that for you, but table 19-6. All patients with an altered mental status should also have a GCS score calculated, so the Glasgow Coma Scale. If you get on the radio for your radio patch and you tell the hospital that somebody has a GCS of 10, and then you show up with a patient that is wheelchair bound at baseline, quadriplegic, something like that, and you gave them that 10 because they have no purposeful movement, that's not helpful. So if you're going to do a GCS, you need to say they have a GCS of whatever your score is, and then if it's not 15 and it's not 3, because those are pretty self-explanatory, it's also important that you know what the things that are different are. So let's see. We got the Glasgow Coma Scale here. So your motor response, like I said, if somebody that is in a wheelchair at baseline, and so you gave them like limited points for their motor response, and you told them that you had a GCS of 10, that's moderate. That's telling the hospital that there's an issue, but you didn't tell them what was causing that issue. They're going to be thinking that they need to be ready for this severe patient, or this moderately severe patient. Whereas if you say, I have a GCS of 13 and I took off points for eye opening, then they're going to know a little bit more. They're going to know that there's something wrong where the patient's not able to open their eyes normally. And that's a different kind of issue than a 13 that's because they are, their verbal response is words. So you want to make sure that you're looking at what the issue is, not just the score. It's helpful. It's a good scale to have and to know, but that alone is just a number. You have to give some background on what that number means. So anybody that you're going for a neurologic issue, you might say to yourself that it's a neurologic issue and therefore their blood pressure itself is not as important, but you want to make sure that you're watching their blood pressure closely This is definitely one every 5 minutes at least for blood pressures, because that change can be a possible change in their ICP. You want to also watch their changes in their pupils. So we're going to again do that perla. You're going to watch and see if there's changes in their pupil size and their reactivity, because that could be herniation, but you also want to be keeping an eye on any nystagmus. If it develops, if they start acting normally otherwise, but it doesn't go away, if it becomes more obvious, like where you had been starting midline with your finger and it was all the way over the side, they had some nystagmus, but now it's almost still while you're midline, they're having that nystagmus. That's a change. So you want to make sure that you're keeping an eye on things like that. You don't want to just check these things once. When you say in your class, in your testing, that you're going to reevaluate and reassess, actually do reevaluate and reassess en route. Things change. Even if you're 5 minutes from the hospital, try and get through it twice. If you're working, since I know a lot of you are coming up to the action area, if you're not already up there, if you're working up in that area, your commute to the hospital is 20 minutes at best. You should be reassessing 2 or 3 times. You checking their eyes, their pupils on scene, and then going to the hospital and being like, oh, they were equal and reactive is not sufficient. Make sure that you're checking them another time or two en route. Oh, here we go. Routine monitoring. So you're going to include heart rate stuff. Notice that it does say glucose level monitoring. You do monitor that. That is a baseline, which shows that it gets every time you read vitals. So if the patient is nonverbal, whether that's baseline or they've just had and they can't verbalize or whatever that, you should be observing their respiratory and body and procedure. They can't tell you on. You still, if you're paying enough attention to what's going on with them and see it. Title oximetry. So is pulse ox. Sounds like you guys have done a lot of stuff with pulse ox. It shows it to be by the blood cell circulated through the heart and then send extremities. It can take several minutes, sometimes even, for, and it's giving you an immediate change in reading. So you also want to is or say they're, make sure that you're not, you want to treat them medically professionally, but you also don't want to traumatize, as far, again, that even though they speak to you, still understand what you're saying. You should be talking through that idea before you just scare them by step. You want to make that when you notify the receiver that you're also giving them the time it was last normal, or in the front of all of your, and that's time of arrival. You make sure that you're, that G, if you have width section is down. If I forget to cut GCS, the doctor gets on, yes, pulling out of my butt. I don't know why, because I have seconds to figure it, and sometimes it takes a little bit longer to figure that out. But tell them pulling it out there and you tell them 6 can help. Even if you switch sections, you're not estimating, yes, you could still give them that number. But the optimal report would be, I have a GCS of 6 and here's why. You want to make sure that you're documenting all of your interventions. So even if you attempt an IV and it's unsuccessful, it should still be documented. You did break the patient's skin. You made that attempt. So still make sure that you're mentioning it. Also, if you attempted an IV and you got flash and then you blew the IV, that's incredibly important to let the hospital know, because if they're going to give a clot busting agent for a stroke and you didn't tell them that you attempted an IV on this massive vein and blew it, then the clots that are holding that IV attempt together are going to be broken. So that's important to note. You might, oh well, it didn't work out like there, but very important to mention. In every patient, you have to check every single leg you attempted, and no, the piece of tube with some tape over I consider it enough to the hospital. Especially let them know about every made to monitor areas, give that agent, sure that there's no bleeding. Patient had to document your findings, make sure that you're finding what you description was like. I want to give a description of the seizure activity, the started, the duration, if more than one, all that kind of stuff is very important. You can document it if you experienced it, if you saw it happen, because it's continuing after you had arrived on scene. But even if you did not experience it yourself, if you did not witness it, what the family tells you is still important and should be documented. In addition to recording your interventions that you perform, you also want to record its response to it. So if you start an IV, give D10, if the patient is suddenly doing better, and you're documenting and helped. So part of the reassessment is reassessing interventions. Also double check, make sure that you have is still patent before you give your medication. If you're working a code and you're about to give IV, IO, see still run normal saline. It doesn't have to be a lot, but before you slam epi, and I always use it because there's a place and kind of the catheter size is full. An IV, you want to make saline through it, because if you slam and you go for 3 more epi, kind of, and you've got epi that's not not doing its job. Make sure that you've checked that normal saline before I give it, so I don't know tissues. So make sure that that is Mr. All right, your emergency medical care. This is the last section. Do you guys want to take a quick brief back?
Can everybody hear me okay? Okay, then that means it's Laurel's computer that's glitchy. Yeah, I'm thinking it's probably the storm.
I think it's back up for the moment. But I definitely lost all of my internet reception for a minute there.
Okay. All right, so do you still want to take 5?
Yeah, let's do that just so that I can make sure that it's back as connected as possible.
Okay, if you need anything, just give me a shout.
Thank you.
Yep.
This conference will now be recorded.
All right, we won't get back into the information right away because I gave people another minute still, but if anybody's here, will you let me know if things seem to be working all right? I switched my mic source.
Yeah, you seem to be good now.
All right. It is also just a general internet issue in the area, so if it cuts out again, I do apologize, but have no control. Does anybody have any questions for anything so far? All right, I'm getting a bunch of notes, but if anybody does have any questions, shoot them on over. Getting back into the last little bit here, we have emergency medical care. So this is the medications and things that you can do to make sure that you're treating properly. So a patient with a stroke, a seizure, hypoglycemia, hypoxia, they all typically show signs that you can identify, symptoms that you can notice, and there are treatment options that are readily available. So your best treatment is going to be determined when you do your assessment and making sure that you're keeping your ABCs in place. So for hypoglycemia, you can give your 2 different medications, your dextrose and your glucagon. You want to give them both only if their blood sugar is low. If their blood glucose level is normal and you give dextrose or glucagon, you could create more issues than you solve. So even if they're having that seizure that's lasting a long time, you can set up that bag of D10, you can have it ready, but don't give it until you have a reading that's low. Because you don't want to create a hyperglycemic emergency by giving too much if they don't actually need it. Like we talked about, glucagon is that IM injection. I don't know if you guys have gone over in your in-person stuff, how to mix it and all that kind of stuff, but it is your last line. You want to give D10 first if you can get that line. And that is, again, because it's looking for the stores. And if you don't have the stores available, then it doesn't do much. Hypoglycemia is more lethal than hyperglycemia. If you can't check a patient's BGL because your equipment failed, you should be more cautious in administering dextrose because you don't want to create a hyperglycemic emergency. But if you can't check it, you want to err on the side of caution if you're going to administer it all. If you can't check it because of an issue with your equipment, but there's a patient has a history of diabetes, you can see if you can check it with their equipment. If your equipment's and their equipment don't match, if yours says that the blood sugar is 20, but theirs says the blood sugar is 120, you need to consider when's the last time that yours was tested, when's the last time that theirs was tested. Try and figure out if there's a way that you can determine which one is the more accurate reading. If they're talking to you and having a normal conversation, they're probably not having a blood sugar of 20, but it is possible. When I took my advanced class, one of my classmates was a diabetic who said that he was still having totally normal neurologic function when his blood sugar was 13. It was a story. I don't know how true it was, but something to consider is that it is possible. So, like we talked about, you want to ensure that your IV line is patent before you attempt to give any dextrose. Again, it says D50 here because it used to be that was what was given. It's been changed down to D10 because of how important it is that the line is patent. So D10 could still have issues for the surrounding tissues. It could still cause some necrosis, but it's not going to be nearly as bad as the ever see it. Oh, I think I'm back. All right, sorry, lost you guys for a minute. So where was I? Oh, if you're unsure, hypoglycemia is more lethal than hyperglycemia. So if you can't figure out for sure what it is, err on the side of caution, do it slowly, but administer that D10 if you really need to. When you are, this talks a lot about D50, but I don't think I've seen that carried on more than like one ambulance in my entire career. So you want at least a 20 if you can get it, even for D10, just so that you can make sure that it's running adequately. But if all you can get is a 22 or 24, it is what it is. Ensure that the line is patent. We'll say it repeatedly because it's incredibly important. It is milligrams of glucagon. I wasn't sure before if it was milligrams or grams because I need to sleep, but it is, you can administer 0.5 to 1 milligram of glucagon intramuscularly if you are not able to get the line. You are able to repeat it for up to 3 doses according to the national curriculum. Most likely you're not going to have 3 doses available to you to attempt. If the patient is able to protect their own airway and follow instructions, then you can try oral glucose. It should be your first shot if they're able to follow those instructions, because you don't want to be doing anything that's invasive unless you need to. But you want to make sure that they're not going to aspirate. So if they can't follow your instructions or have a decreased level of consciousness or aren't protecting their own airway very well, don't give it. There is no safe way to lower your high blood sugar if you do too much. If you have somebody with a hyperglycemic emergency, if their blood sugar is 500 and they're like in that ketoacidosis or something like that, you can give fluids and hopefully thin out that blood sugar enough. But you're not really lowering it. So you're going to want to try and reorient the patient as much as possible, because confusion, they're usually going to be confused. For stroke, your care is going to be that you're going to assume that any patient that's experiencing stroke-like symptoms is having a full stroke, because you can't determine that it's TIA until those symptoms disappear. So never treat a stroke as a TIA. Always treat a TIA as a stroke. You're going to administer supplemental oxygen as long as their oxygen level is not 100, because again, you don't want to create those free radicals. But you should have it available if they're like bordering on that 94, 95 area. Grab a nasal cannula, because if it goes down, that works. Here it's saying elevate the patient's head to 30 degrees. I've heard 45. I think that's what we talked about earlier, was 45. If it's telling you 30 in the textbook, we'll go with 30. You want to try and get your IV access as soon as possible for a stroke patient. If you can grab blood labs for the hospital, if you're transporting to a hospital that accepts your labs, do it if you can, but don't risk losing your IV for it. Your goal for a stroke is at least a 20 gauge IV, because they need to be able to give all of the appropriate medications that they have on their end and a 20 is the most helpful if they're going to a CT and there's a possibility that they're going to need the medication for the CT. That needs to go through a 20 or larger whenever possible. It should also be in the AC if possible. Depending on which hospital you're transporting to, if you're familiar with your hospital's layout for CT and you know which arm they prefer and you're able to remember all of that information and put it in the proper arm, that's also helpful. If you don't know and you can't remember, a 20 or larger in an AC is still great. This is one that you want to make sure that you're calling early to the hospital, because they want to make sure that they need to register the patient. So you want to call on the phone for a stroke alert whenever possible, because you're going to give the patient's name and date of birth over the phone. You can't do that over the radio legally. And if they get them registered, then they can bring them straight to CT. Whereas if you don't call in advance and give them all that information, they may have to pause at the door to get the patient registered. So you want to also watch for seizures, because there's so much stuff going on in the brain that the brain could try to react by firing in ways that it doesn't normally, and that could present as a seizure. It says here, call early for paramedic backup. In general, a stroke is something that an advanced can handle. There are aspects, seizures, if their airway is not going to be secure, things like that, that a medic might be useful. Hopefully the medics that you work with are going to be willing to come out and do an assessment, and they're not going to hold it over you if you call them and then you didn't need them, especially as a new way. You're taking on some responsibility and information that you didn't have before. And if it takes you, even like if it takes like a year of you calling a medic for almost every call, they might resent you a little bit for every single call, but hopefully they're not going to hold it against you if you're calling out. Ask for help. It's a sign of a better provider to know when you need help and ask for it, than to try to go in and show them how big your pants are and get somebody hurt along the way, because you just wanted to be the best. So call for that help when you need it. So your carbon dioxide and oxygen levels are very important for patients with increased intracranial pressure. Low oxygen levels can it can markedly increase mortality in any patient with a brain injury.
You don't want to hyperventilate. So like I said, if you're looking at a 35 to 45 and you can get it down to 35, that can be useful, but it used to be that they preached to go down to 25 on that end tidal, and that's no longer the case. You don't want to hyperventilate them to the point that you're pushing them outside of that normal range. If you can have them on the lower end of the normal range of that end tidal by ventilating a little bit faster, but still within that like less than 20 times a minute, go for it. But don't hyperventilate to the point that you're breathing for them like 60 times a minute. You should not be administering a breath a second ever. So for a stroke, aspirin should only be administered after a CT or an MRI has been completed in the hospital. So even if the patient is presenting in a way that you think that aspirin might help, if you're like, oh, I'm pretty sure that it's a clot and not a hemorrhage, then still just wait until they've done the imaging, because you don't want to cause further issues if it is actually hemorrhagic. So this has the adult suspected stroke algorithm from the AHA. I believe it is also in your textbook. But that's some information for you. Just in case I lose my mic again, I'm not going to linger on it for too long. So TIAs. So like we talked about, you're never going to want to treat a stroke as a TIA, but you always want to treat a TIA like it's a stroke. So you're going to follow the same exact guidelines as for a stroke, unless all of their symptoms have resolved, in which case you should let them know that having had a TIA is a warning sign that they are likely, it puts them at a higher probability of having a stroke in the future, because it means that there was a buildup somewhere of those, that clot. And if it does it once, then it's definitely at risk of again. So people that have TIAs are at higher risk of someday having a stroke than patients that have never had a TIA. So seizures. So seizures, again, are sometimes hard to identify. At the hospital, they're going to check the blood levels of the seizure medications to make sure that the patient's getting the right dose. That's something that you're not able to do, but if you ask them again in that assessment, in that history taking, about their medication and how well they're taking it, you may have an idea. Patients who have had a first seizure and patients who have experienced chronic seizures but have one that's different, definitely try and get them to go to the hospital. You're going to want to administer oxygen unless they're at that 99 to 100. I see that Michael Ball put in the New Hampshire stroke protocol. So yes, at least a 20, but an 18 gauge is the preferred. And I didn't realize it was the right AC at all hospitals. I thought it varied from hospital to hospital, but if it's right AC for all hospitals, then that's easier to remember. So thank you for that. So with recurrent seizures, if they're in like a status epilepticus type situation, you want to make sure that you're protecting them from further injury. Like we said, we're going to put the blankets, the towels, the pillows around them as much as possible. We're going to make sure that we're watching their airway. We're going to have suction ready. If needed, you can breathe for them, and you're going to transport quickly. Call for a medic. You're going to get IV access, even if you don't think that you need to give anything yet. Make sure that you have it. Because like we talked about, if you find later that their blood sugar is now 20, you want to already have it in place. You don't want to now be panicking because they're seizing and their blood sugar is 20 and you have to get a line. So you want to make sure that you have that medication list, and you want to find out if they're having multiple seizures, did they regain full responsiveness between seizures? And you're going to find that out from the family if it was before you were present. if trauma was involved and the patient was standing up and then had a seizure and collapsed to the ground, you want to consider spinal immobilization if needed. So make sure that you're considering not just that they had a seizure, but the trauma that they may have sustained based on their body's reaction to that seizure. If you're treating a child who you think is having a febrile seizure, you want to try to lower the body temperature. Be careful not to lower it too much and cause them to shiver. But if you are able to bring them outside because it's cooler outside to do your assessment, but it's not freezing, you might want to consider that. Syncope, so you're going to determine whether the patient experienced trauma when they fell. We're also going to consider, like we talked about, syncope sometimes presents in a similar way to seizures. So you want to see if the patient's family can tell you anything about what the patient looked like when they had that syncopal episode. You're going to, again, consider if you need to take spinal precautions. This is one that you really, really want to make sure that you're getting that 12 lead on, because what causes them to have the syncope could be cardiac. Same with strokes. We talked about strokes should get 12 leads to make sure that it's, see if it's AFib or not. Again, blood sugar in all cases, anything neuro, blood sugar. You want to consider orthostatic vital signs. As a field, as a career field, we're not great at orthostatic vital signs. We talk about them, we say that we're doing orthostatic vital signs, but does anybody truly take orthostatic vital signs properly in the field? Probably not. I know if I do orthostatics, I have them lie down if possible, and I take a blood pressure, I have them sit up, I take a blood pressure, I have them stand up, I take a blood pressure, and then I call it orthostatics. True orthostatics, you're supposed to have them like sit up, and then it's supposed to be 5 minutes later or something like that. I don't know the exact timeline because I don't do it appropriately. And probably if you're doing orthostatics, you don't do it appropriately either. And that's okay, because none of us do. Don't be too set on your orthostatic findings. 2 minutes from that, okay. If you're not doing it by the textbook, because it can be different. It needs to be like a difference of 10 points systolic or something like that to be considered important enough of a finding. If I find a difference that makes me go, that's different, even if it's 30 seconds after they stood up, I still consider that important to me. And I wonder if it may be related to an orthostatic issue. I also ask them, instead of just checking their blood sugars, I ask them, or their blood pressures, excuse me, I ask them if they had just stood up before they collapsed and if they felt any dizziness when they stood up. That could be indicative of that orthostatic issue. It could also be because they're dehydrated, which could lead to orthostatic hypotension. So consider also dehydration. You're going to provide fluids as appropriate. So that's if you're considering dehydration or just they have some hypotension in general. Syncope can be absolutely benign, but it also can be a sign of a life-threatening medical condition. So make sure that you're calling early for paramedic backup if you feel like you need it. And our last one, headache. This can be indicative of something more serious, but in general, there's not really anything that you can do for 911. Even a migraine, you're just gonna kind of give them a dark space as much as possible. You're gonna try and keep it as quiet as possible. We recommend that you don't use lights or sirens while you're transporting for somebody that's having a headache, because you're probably gonna make their headache worse, unless you think that that headache means that they're having a hemorrhagic stroke. In which case, yes, your head hurts and we're sorry, but we're going to drive very fast. within reason. So standard care. And that's the end of my slides. Does anybody have any questions on anything we covered? Before everybody signs off, while you're typing up any questions you may have. I was asked to remind you that you do have a quiz that will be open and available to you starting at 10 p.m. Let me make sure that it was quiz and not test. Yes, the quiz is posted and opens at 10 p.m. So if anybody does have any questions separately that you don't want to discuss with the group or anything like that, I will turn off the recording for the lecture in the next minute or two, and I'll stay online for 5 or 6 minutes if anybody wants to reach out privately for some reason. But otherwise, that's all I've got.